Good afternoon, everyone. I want to welcome you to today's webinar entitled Decarbonization and Climate Resilience in Healthcare, a focus on the clinician. This is part one of a webinar on decarbonization. Part two will be focusing on hospital infrastructure, and this will take place on December 20th. And we will be making sure to share details about registrations and all of our recordings with all attendees. So my name is Dr. Sherry Weiser, and I co-founded and co-direct the University of California's Center for Climate Health and Equity. I'm very pleased to kick off the webinar today. The mission of our center is to harness the expertise and leadership of the health sector to drive ambitious climate action for health and health action for climate. And I'm especially excited that our center is featuring two clinicians and really leaders in their field to learn about the decarbonization work they are spearheading in their practice. And we are hope and are pretty sure that attendees will be inspired to take action in their own clinics, health systems, and hospitals after hearing about the really exciting work of Drs. Gandhi and Sherman. As we launch our series of fall events, I also wanted to thank both the UCSF Office of Sustainability as well as the UCSF Academic Senate Committee on Sustainability for their support and contributions. And it is now my pleasure to introduce today's webinar moderator, the managing director for our center, Dr. Sapna Thotatel. Prior to joining the center, she was an associate director of sustainability in the University of California's Office of the President, and her expansive portfolio included supporting decarbonization activities in all 5 of the University of California's health systems, also working on sustainable food procurement and health and wellness. She has worked on environmental policy for multiple organizations, from the U.S. Environmental Protection Agency to Healthcare Without Harm, and has published books on sustainable food and farming. She received her PhD from UC Berkeley in geography and her Master's of Science from Oxford University in environmental change and management. And I will turn it over to Sapna now.
Thank you so much, Sherry, for that introduction, and thank you all for being here today. Sherry mentioned that my background involves supporting decarbonization in the University of California's health systems, and much of that work was very building focused. So I'm really looking forward to hearing from and learning from our speakers today and how we can scale up climate action and clinical care in a way that bolsters and doesn't compromise patient care. So our first speaker is going to be Dr. Jody Sherman. Dr. Sherman is an internationally recognized researcher at the emerging field of sustainability in clinical care. Dr. Sherman is a member of the Lancet Countdown on Health and Climate Change and was a contributing analyst for the UK National Health Service Net Zero Initiative and serves on the National Academy of Medicine Action Collaborative for Decarbonization of the US health sector. She also co-leads the Lancet Commission on Sustainable Healthcare. That was a very truncated bio, by the way. You do so much more than that. So please all, Google her and check out her work. And I'm going to say the same about Dr. Seema Gandhi. I'm going to present a truncated bio and Google her as well because she does a lot of amazing work. Dr. Gandhi is an anesthesiologist and the medical director of sustainability at UCSF Health. At UCSF, she has engaged colleagues to eliminate desflurane, an anesthetic gas with the highest global warming potential, and spearheaded a multidisciplinary team to implement a clinical decision support tool for the adoption of low-flow anesthesia practices to decrease direct emissions of greenhouse gases from the operating room. Additionally, Dr. Gandhi's efforts have guided the remaining UC Health campuses for others to implement similar emissions reduction practices. Before I turn it over to Dr. Sherman, who's going to be speaking first, I wanted to let you all know that we will have a few minutes at the end for Q&A. So please submit your questions in the Q&A function of this Zoom webinar, and we will attend to them later on in this session. So Jody, I'll let you take it from here.
Can you hear and see my slides okay?
It looks great.
Well, thank you very much for that kind introduction and for the privilege of speaking for the UCF Center and of course sharing the stage with my colleague and friend, Dr. Seema Gandhi. This panel focusing on clinicians, we thought it'd be helpful to take a high-level view of healthcare pollution and really hone in on what clinicians can do. And really want to start normalizing this language of planetary health and planetary health care. And really, this is about expanding our duty of care from the individual patient in front of us to also include public health and ecosystems upon which all our health depends. Some disclosures: I do receive grant funds from the Canadian Institutes of Health Research and the Commonwealth Fund, and do serve as faculty for the Institute for Healthcare Improvement. None of this is related to this talk, however. From a very high level view, this was from our contribution to the Lancet Countdown on Health and Climate Change. It's important to know that the healthcare sector is a big polluter. While a lot of this conversation is going to be about greenhouse gas emissions, it's not the only type of pollution of concern. But nonetheless, we know that globally, the healthcare sector emits more than 5% of total global greenhouse gas emissions. And the US is an outlier, not in a positive way. We are responsible for 25% of global healthcare emissions, even though we're only 4% of the population. So we have the highest per capita healthcare greenhouse gas emissions. Now, if we had the healthiest population in exchange, one might argue that there is some benefit to that, but we actually don't. So if you see here on the x-axis, we plotted greenhouse gas emissions for the healthcare sectors on the national level. On the y-axis, we've associated some measure of health system quality. And in this case, from the IHME's Healthcare Access and Quality Index, we've done similar associations with several indicators of health system performance, and the story is about the same. That diminishing returns happen around 400 kilograms of CO2 emissions per person, after which there's no benefit from health system performance in terms of emissions. And at the same time, we know about a quarter of services globally are deemed inappropriate or low value. Half the world lacks access to essential health services. 11% of the population in the United States is uninsured, about half is underinsured. And so some positive message here is that there actually is opportunity for us to reduce the emissions without compromising, in fact, with even opportunity to improve healthcare access and quality. Now, again, as I mentioned, this isn't just about greenhouse gas emissions. If we look at greenhouse gas and non-greenhouse gas pollution combined, the disease burden caused by the healthcare sector in the US is close to 400,000 disability-adjusted life years. That's mostly from particulate matter, but both greenhouse gas emissions and air pollution, like particulate matter, is primarily stems from combustion of fossil fuels. So that points to where we should intervene. We noted that the harm from the dailies is on the same order of magnitude as harm from medical errors. That's first reported by an Institute of Medicine. Why this matters is that this famous this famous publication, To Err is Human, sparked the patient safety movement in the United States. We thought we were doing a good job in keeping patients safe until this report came out. Then we realized we weren't, that medical errors is a leading cause of harm. And after this report, entire systems and institutions became normalized within healthcare delivery to try and keep our patients safe. And what we're saying here is that pollution is on the same order of magnitude as medical errors that sparked this whole movement. And that pollution prevention really is the new patient safety movement, and it ought to be considered the seventh dimension of quality of care. Now, we can reduce emissions, obviously, by providing less care. That's not the goal. What you're seeing on the left is the famous graphic coming from the Planetary Boundaries work. And what you see here is that we are exceeding the planetary's ability to regenerate itself in multiple dimensions, climate change being one of them. As I mentioned, it's not the only type of emission of concern, but we can reduce the amount of pollution and emissions by providing less care. That's not the goal. We also have to ensure that there is a safe and just space for all humanity. So not only do we have to mitigate our emissions in the US, but in order to do so, we need to transform care delivery. And in order to do that, we need to know where the emissions are coming from. And multiple studies have shown the same thing. The vast majority of the emissions are coming from the supply chain. Multiple studies, 70 to 80% of the supply chain especially pharmaceuticals and chemicals and medical devices, and anesthetic gases and metered dose inhalers are 5%. This is from the UK, where they have better procurement data than we have, but when we look at other studies, the results are very similar. And there are two ways of thinking about how to reduce these emissions. One is to reduce inappropriate consumption of resources. So those are affected by things like clinician behavior, culture, but also regulatory and oversight complexity. And there are a lot of policy drivers of this waste that need to be addressed. The other is to reduce the emissions embodied in the stuff that we use and the care that we use. And that's more on industry, but it also is us as well, because we influence procurement policies. Clinicians are very involved with formulary decision making. So, and then where care occurs, whether it's in a resource intensive hospital setting versus a home care setting. So there are different ways to reduce wasteful consumption of resource, and then the emissions embodied in care. And so from a clinician perspective, I like to think about that there are different levels that one can be an actor on. The micro level, pretty much everybody has the capacity to make a difference in their personal practice. Clinicians can also get involved at the meso level, meaning their organization and administration policies. And then they can get involved at the macro level. So for example, national professional society policies, for example. So everybody can do something. People are drawn to different areas of activity or more than one area. The important thing is to do what you can. And so I'd like to point clinicians to what we call the Planetary Healthcare Framework, a way of thinking about the different areas where clinicians can be active. And these different areas are a different way of thinking about those micro, meso, and macro levers. And so I'm going to go through each of these quite briefly. So the first is the reduced demand for health services. So that means addressing the social determinants of health, doing health promotion, disease prevention, and better chronic disease management. If we can reduce disease incidence and severity, then we can reduce the amount of care and the intensity of care. This is a tall order. That's not something I do as an anesthesiologist. It's more in the realm of primary care, but we do have lots of specialties that have hands in primary care. But importantly, when you look into the social determinants of health, is to pay attention to the fact that the environmental and social determinants are things that have nothing to do with medical care. In fact, it's been determined that health care contributes to maybe 20% of health, and that behavior is another 20%. But most of it are the factors or the circumstances that we find ourselves in, and why equity is tightly wound to healthcare pollution and its mitigation. So when we think about reducing demand in an individual practice, things like supporting the anchor mission through connecting our patients with community and social services, social and nature prescribing, integrative therapies, and active transportation and whole foods, plant-based diet accessibility. So we can prescribe these things. We can also advocate for them in our communities. Primary and secondary prevention, so things like cancer screening, smoking cessation, vaccinations, ensuring that these are maximized. And of course, doing a better job with chronic disease management, especially things like blood pressure control and diabetes management. If those are properly managed, we can stave off and hopefully even prevent things like renal failure and hemodialysis. There's a lot of work looking at both the fiscal cost and the environmental cost of hemodialysis. We do a better job with chronic disease management. We stave off that and minimize those emissions. The next layer within this planetary healthcare framework is this concept of matching supply of health services to demand using economics thought, meaning that we have to ensure that we have primary community care services that are adequately utilized, and we have to ensure that care is appropriate, that it's wanted and needed, that it's not given if it's not wanted and it's ineffective, and then resource stewardship, that we are ensuring that we are using supplies and materials when they're indicated and when they're not. So we need to both avoid underuse of services and overuse of services when we think about what is meant by appropriateness. So underuse can lead to avoidable disease, as we just talked about with prevention, and overuse leads to harms that are also avoidable. So an example of inappropriate care, overall unnecessary interventions and investigations are responsible for about a quarter of health services. This is a famous work by Don Berwick, over 100 billion annually in costs that could be avoided in the US. And then appropriate care, this is part of, again, what is meant by high quality care. It's dimension of quality. And really it arrives from system structure and funding structures, but also clinician behaviors. So we are influenced obviously by those systems, but we also influence those systems. So one example of inappropriate care is unnecessary blood work. This is from the team out of University of British Columbia that recently looked at the environmental impacts and costs of unnecessary blood work for surgical cases. And what they found at this very large health system is that 3/4 of patients got at least one unnecessary blood test. This is consistent with work in the United States as well. In fact, they also found 4.4 excess vials per patient, an additional cost of $10,000. Excuse me, that one's not per patient, but the last one is 61 kilograms of CO2 emissions avoidable per patient. So there are lots of reasons why we do blood work unnecessarily, but the impacts are not only to the environment and to the hospital, but to the patient. So unnecessary discomfort, blood loss. In fact, patients that get too many tests can become anemic, sometimes even requiring transfusions. And false positive tests lead to more tests or potentially unnecessary procedures. And then to the hospital, not only equipment and supply costs, but personnel costs, and they can delay urgent processes that are actually needed. And when we think about the environmental impacts, it's not just what we throw away, but it's also the resource extraction, the mining, the manufacturing and transport. So the entire life cycle of those products. So there's lots of reasons to avoid unnecessary blood work. And so when we think about ensuring appropriate care at the micro, meso, macro level, on the micro level, it's really important to adhere to evidence-based practices, avoid technology or indication creep, where we hear something is good for one thing and why not use it for another. Then to really engage in shared decision-making that, again, gets to providing care that is wanted and needed. If a patient doesn't want it, just because we would want it or we think it's a good idea is insufficient. At the meso or institutional level, better care coordination, that we're not duplicating tests that are being provided by other clinicians in the community, ensuring institutional structures to promote best practices. So decision-making tools, for example, that can help keep staff up to date with best practice, and these protocols for de-adopting low-value care, because as care develops and improves, if we don't keep our training up, then we may fail to de-adopt the old ways of doing things. So systems need to be in place not only to adopt best practices, but to de-adopt older, less beneficial practices. And at the macro level, working with our professional societies and organizations to develop clinical practice guidelines and standards that include environmental stewardship and low carbon care. We could be working with our agencies around payment models that discourage low value care. And we could advocate for things like universal access to healthcare. So just some applications of that. So the third stream of thinking in the planetary healthcare framework is this concept of reducing emissions from supply of health services. And there are a number of actions, including green infrastructures and operations and decarbonized transport, technological systems and so forth, which will be covered in an entire other webinar. Since we're focusing on the clinical side here, we'll talk more about the circular economy, say something about virtual care, which is related to coordinated care. So just one example, comparing a reusable and disposable, which is really This was done well before the pandemic. We have long known that reusable textiles are better from an energy perspective, a water perspective, a solid waste perspective, a carbon perspective. And we've known, we appreciate better since the pandemic that they also support resilience. And so it's really important to tie the case to resilience as well. So just an example of comparing reusables and disposables. Disposables are sometimes what is indicated from an infection control perspective. Sometimes things that are cheap and very difficult to clean ought to be disposable, but we're way out of balance with how much disposals we have. And we really need to think about what the disposable label means. It's actually an industry label. It's not an FDA label. So the single-use disposal label does not mean that something can't be reused. There's an entire third-party reprocessing industry, for example, that takes discarded single-use devices, cleans them, tests them for safety, repackages them, and sells them at a discount for additional uses. It's highly regulated through the FDA. It's a very safe procedure, but it really begs the question of what this disposable label means. And if we can reuse things that are so-called disposable, why aren't we just making them more durable? That's a whole talk in and of itself. Also, this concept includes things like optimizing drug package size. So on the left is an example. When I first started practicing at my institution in the operating room, we had these 10 ml vials of insulin that contained 10,000 units. And on average, we need to give 5 units to a patient, and regulations would require us to throw them away. One of the first actions I was able to do is at least get that to a smaller vial, so a 3,000 unit vial, but still worth throwing away, more than 99%. We also had some safety issues. There are a lot of safety benefits from making these dose size. So then we had our pharmacy create ml, but still we're throwing away 95%. So really we're down to this idea of package dose sizes. Here's a syringe with just 5 units, which is the standard amount that we use in the operating room. And it's really rather ironic that when patients are rationing their doses of insulin because of skyrocketing costs, and actually we know there's not even enough insulin around the world to support the needs of the patients that need them, that we're throwing away 99% commonly of those medications. Just an example of how we can be better stewards of our resource. There are a lot of regulatory barriers and even financial payment barriers that make this challenging to do. And so we need to address them at the macro level. Here's a paper led by my colleague, Andrea McNeil, which I highly recommend, Transforming the Medical Device Industry to a roadmap to a circular economy. Circular economy doesn't just apply to medical devices. It applies much broader than that. But just to explain, what we have is more of a linear economy where we make stuff, we use it very briefly, and then we toss it away, so-called take, make, waste. The idea of a circular economy based on natural systems, there's no such thing as waste in nature. The waste product, the so-called waste product of one system is a feedstock for another. So the idea of the circular economy is really based on that principle, where we really need to keep stuff in use at its highest value for as long as possible. And then to repair and reuse things and repurpose them when they can't be used for their initial intent. The last thing you want to do is recycle. I mean, it's better than nothing, but it's really a very low impact sustainability solution. But really need to move upstream to reduce waste to begin with. That is really the better value add, and that includes redesigning things to make it easier to reduce waste. And so why do we have the driver? What are the drivers of a linear economy? There are multiple, but including consumer drivers. So, we want to avoid liability. We want to avoid complexity in the care that we provide, with all this production pressure, safety concerns, forcing us to just throw things away because it's easier. Manufacturers want to maximize profits, and they want to sell as much stuff as possible. And the regulators make a lot of assumptions of approved safety in the case of single-use devices that by and large lacks evidence. And so we really need to do a better job of taking a rational approach of when it is appropriate to use disposables and when it's not. There are times where it is, but we need to do a better job of delineating when that is. So an example at a different level of action, thinking at the, so we talked about devices. Now we're going to talk about something called the clinical care pathway. Here's an example from my own specialty in anesthesia. We've got many different ways to make a patient comfortable for their surgery. Sometimes there are indications based on patient reasons or the nature of the surgery where we have fewer choices, but sometimes we have a lot of choices. And in the case of clinical equipoise, we should factor in environmental concerns. We know inhaled anesthetics are potent greenhouse gases, so we hypothesize that any anesthetic approach that used inhaled anesthetics would be far worse from a greenhouse gas perspective, and that's what we found here. So if you just squint at this, any of these combined approaches that use inhaled anesthetics have significantly greater CO2 emissions versus things like, here's a patient getting an injection for a spinal anesthetic, here's a patient getting their arm numbed up for some surgery of their limb, and we can even do general anesthetic or sedation with intravenous medication. So the inhaled anesthetics, if we have a choice to not use them, that is something better from an environmental perspective. Virtual care, obviously quite popularized during the pandemic. Here's a great paper on the effect of home monitoring using a mobile app that avoided in-person clinic visits. So just an example of where virtual care can be beneficial from an environmental perspective. Also can be more convenient for patients and staff, so more desirable from a quality perspective. But I think we have to be very careful to just not simply assume that telehealth is better for the environment because patients are driving less. It still requires more technology. And to not simply assume that because patients are maybe even staff are driving less, that it is the best approach. Sometimes a lot of virtual care is actually taking place in the same four walls as a patient would see their clinician. And it's not always appropriate to do virtual care. So, we can't simply say, let's shift to telehealth and we'll save a bunch. There are indications and instances where it is better, and we have to be very mindful about where it is. Probably seen inhalers. I in the news, I've certainly mentioned that up front. That is a significant part of the health sector footprint. Between 2.5% and 3% of a national health sector footprint can be coming from these inhalers. Notably, the pressurized metered dose inhalers. A single albuterol inhaler is the carbon equivalent of driving 200 miles. 55 million dispensed annually in the United States, the carbon equivalent of 500,000 cars on the road. And we do actually have multiple alternatives that have significantly fewer emissions. And there are instances where patients need the pressurized metered dose inhalers because what it is it's a gas that's pressurized. So it forces the medication into the patient's lungs. If you don't have that, the patient has to draw the medication into the lungs, and not every patient is strong or technically capable of doing so. So there will always be instances where we need pressurized metered dose inhalers. But importantly, if we look to an exemplar, for example, Sweden, 88% of their outpatient prescriptions are for non-pressurized metered dose inhalers versus in the United States, only 25%. So there's an exemplar to look up to there. So achieving circular supply chains, again, getting back to micro, meso, and macro levels. At the micro level, we can reduce material consumption. We can select lower carbon drugs and reusable devices when we have choices. And we can innovate our practices because we know what's appropriate. At the meso institutional level, we can get involved with environmentally preferable procurement. Just a note to be cautioned, there's a lot of greenwashing out there, which is really why I try to focus on waste reduction. But certainly we need to move towards what's called EPP. We need evidence-based infection control practices, and we need policies in our institutions for rational use of single-use disposables. And at the macro level, we need to get involved with the professional societies around guidelines that influence such decisions. And also work with accreditors and also with manufacturers. And then finally, just to sum up this planetary healthcare framework, I've covered most everything here, the three streams of thought really concisely. The first is reducing emissions embodied within healthcare services. So electrification, which has to be combined with clean energy. You're going to get a whole talk on that. So we didn't cover that today, but certainly we covered circular economy and resource stewardship as being fundamental and things we have control over as clinicians. Matching supply with demand, meaning we need to avoid inappropriate care, and then moving way upstream, and that's reducing demand for healthcare to begin with through health promotion, disease prevention, and addressing the social determinants of health, and really just expanding what we consider high value care, which traditionally is thought as the best outcomes for the most patients at the least cost. That's a traditional view of value, but we also have to think about minimizing environmental and social harm. And I thank you for your attention.
Thank you, Dr. Sherman. I am thankful, grateful to be a part of UCSF's Climate Change Health Equity Center, and importantly, share this podium with you, Dr. Sherman, because a lot of the work that a lot of us have been doing is based on some pioneering work done by you. So it is a great opportunity, and I'm thrilled to be here. While Dr. Sherman has talked about sort of a broader picture and given you a sense of so many different areas that we can get involved in, from planetary health card to social determinants of health, I want to zone in a little bit on sort of case studies and examples of things that we've done here at UCSF to help us get towards our decarbonization goals, and talk a little bit about how do we get involved. And this is for everyone, whether you're a clinician, you're an administrator, you are a staff member, you're an educator. So there's a little bit of this for everyone here to get involved in our race to decarbonization. Now, don't want to drag the point, but we know at $1 trillion, we are the most expensive healthcare in the world. At 8.5% emissions, when the global average is about 4 to 5%, US healthcare is the most polluting healthcare. And no one needs a reminder on how vulnerable we are, especially in Northern California. We've seen heat waves, we've seen fires, and we've seen our health system brought to its knees. We've seen how vulnerable we are, right? At least my inbox every day is filled with emails about back order, where it's a drug, it's a supply. So we are very aware of that. And sadly, the impact of this status quo is felt by the population that have least to do with this. They're the least contributors, the marginalized population, our underserved population, but they do see this impact of the choices we make every day, right? But there's good news. And I often thank President Biden in a lot of my talks, because when he decided to sign a pledge with 40 other world leaders to decrease emissions from US healthcare, it led to a cascade of events. And now we know the National Academy of Medicine has task forces around it, which Dr. Sherman is involved with, the new developed Office of Climate Change and Health Equity, and all of them are saying the same thing. We can't do this alone. All of us on this screen, people we interact with, and everyone nationally who's involved in this industry of healthcare is responsible. And whether we are providers, payers, involved in manufacturing, device makers, clinicians, policymakers, together, we're all responsible for getting us to our healthcare decarbonization goal. We're all responsible for the current state of affairs. And to accept the level of emissions from US healthcare as collateral damage for providing the quality of care we do is no longer going to be acceptable. Healthcare has been implicated. To look at itself very closely and see what it can do to decrease its carbon footprint. So this is a broad audience, right? Whatever your interest is, if you're a researcher, because currently we do lack a lot of evidence, We do lack support we lack funding to carry on further research studies. So as a researcher, you can get involved in this, and I know Dr. Sherman has definitely done a lot of this. As an educator, CCHE has done a lot of work around educating medical students, making it a part of their curriculum, working with graduate medical offices, working within each department. And that's definitely what we've done in our Department of Anesthesia. Sustainability focused education is our part of our mandatory didactics. No resident will graduate anesthesia training at UCSF without going through a certain amount of hours of education around environmental stewardship. Incorporating this into our QI framework. So those are the things that we've adopted here, right? I'll share about some of the mitigation work we're doing. And last but not the least, and probably one of the most important, is to make our voices heard and get involved in advocacy at an institutional level, at a societal level, and at a larger policy level, whatever your area of interest is. Right. Now, Dr. Sherman presented this in a different way, but a few things I wanted to highlight here is when we talk about emissions that come from healthcare are divided by scope 1, 2, and 3, and scope 1 is where anesthesia gases lie. Now we know a majority of these emissions come from traditionally outside the healthcare, from its supply chain. And we talked about clean energy and other things, but I'm going to focus mainly on case studies and what we've done and leave you with some tools that you can take back to your institution as soon as you hang up from this webinar. So a few things I want to talk about is what we've done in scope 1, ongoing projects to reduce emissions from scope 2, and a few selected cases on how we've tried to impact our scope 3 emissions. So anesthesia gases, we know, potent greenhouse gases. When we started this about 8 years ago, the two things I want you to look at now is nitrous oxide and desflurane. And both of these are potent greenhouse gases. Desflurane is 2,500 times worse than carbon dioxide. And nitrous oxide about 265 times more potent than carbon dioxide. But not only that, it affects the ozone layer and it stays in the atmosphere for more than 100 years. Now, how these gases are used determines how potent and what their impact is going to be on the environment. Gases can be used at a low amount, like 0.5 liters a minute, or up to 5 liters a minute. And when we embarked on this, there was an arbitrary policy, not evidence-based, not data-driven, and definitely not followed by our European colleagues. This is where I pause to say, US policymakers need to look at data, need to look at evidence, and we need to be champions and voices for that as clinicians. So we created this homegrown tool where anesthesia providers would be alerted if they were using too much anesthesia gas. And a little yellow box would pop up on their electronic record to say, hey, you're using too much anesthesia gas. Do you need to use it? Is there any way you can decrease? Mind you, majority of this gas is not used by the patient. So the patient care does not change. The safety and the quality of the patient care remains the same. All we're talking about is the amount of gas that is vented into the atmosphere. And we saw tremendous results. When we implemented this in 2018, you can see the drop in our anesthesia consumption. And further, we tweaked it to decrease our utilization even further, and you saw the result thereof, right? As we talked about, this is $1 trillion plus economy. And with that, every hour of anesthesia that uses general anesthesia here at UCSF, we're able to save not just the environment by decreasing our greenhouse gases, but add financial value and prevent waste. So this is something that we tried to start off with early on, at least in my career, looking at anesthesia gas. Again, another gas that's involved in scope 1 emission is nitrous oxide. Now at this time, there's some data coming out of Australia, UK, and definitely our colleagues here in Providence that said about 80 to 90% of nitrous oxide that we purchase never actually makes it to a clinical patient. And this is because nitrous oxide is the way it's stored in cylinders, and because of its boiling point, a lot of it passively leaks. There's no problem with the system, it's just the way the gas has to be stored. So we embarked on collecting our data of nitrous oxide utilization through electronic health record, and we found the same amount. Looking at different campuses within UCSF, about 80% of our nitrous oxide that we purchased was never making it to clinical care. So we were among the first hospitals in the country that said, okay, we're not going to install piped nitrous. It will be available to patients, but only via smaller cylinders where the rate of leaking is less. And just this effort decreased or saved us financially by 1.2 million because we're not installing these copper pipes. But in addition, we're also able to, as I said, nitrous stays in the atmosphere 100 years and is 200 plus times worse than carbon dioxide. So we further made steps to reduce our scope 1 emissions from hospital buildings. Right? And as we're doing this, we're like, why don't we expand further? This is looking at about 100 plus cases. Now, mind you, this is a very new field for all of us. So if you embark on healthcare decarbonization, whatever your role is, right? I didn't go to med school thinking I'm going to spend countless hours dumpster diving. Most of us did not. We didn't get taught about healthcare decarbonization. Climate change wasn't sort of part of our core didactics, but it's upon us now. And there's enough area to learn. And thankfully, there's a lot of support right now in this space. So we audited cases to say, okay, where does our waste in the operating room come from? Because you see bags and bags of waste at the end of every case. And these are some of the areas that we found is blue sterilization wrap, foam that is used to position patients. And an area that Dr. Sherman talked about is surgical textiles. Blue towels, which are made from 100% cotton, and surgical gowns that the surgeons use. Now that made up about 30% of our waste. And foam, there are alternatives. We can use reusable gel for positioning. And in fact, that is used across many centers in the country. And so the current things that we're doing now is working with vendors who will take blue sterilization wrap back for recycling. We have an entire effort across all the campuses to move from single-use foam to reusable gel. But what I was really excited about is talking about surgical textiles. So this was a survey that we did across 2 centers, us and UVA, to understand what did our other colleagues think. And the good news is that everyone wants to do something about it. Our surgical colleagues almost unanimously want to try reusable textiles. And they agreed that they're a big part of the problem. And they want to be a part of this solution as well. I've put an email here, and the project is still, because we're trying to find vendors, the project is still ongoing. A lot of surgeons have emailed and said, Seema, what's happening about reusable textiles? We want to use this. We want to start doing what we can to decrease emissions. And so this was a very successful pilot that we have, and good to know that hopefully in the next fiscal year, UCSF will change from single-use to reusable textiles. And this is going to save us literally hundreds of tons of landfill waste, right? Similarly, this was pre-COVID, we used to buy 600,000 single-use isolation gowns. And we piloted it across 5 units at Parnassus. And now we have reusable isolation gowns, which was very serendipitous because during supply chain shortages at COVID, we were covered, we were secured in that end because we use something that is reusable. Not only did this prevent cause significant financial savings, but also significant landfill diversion. Right. So I'm going to pause here and sort of just change gears and talk a little bit about policy and perceptions around infection, which is leading to single-use plastics, which is ubiquitous with our life right now, right? There's plastic in water, there's plastic in food. So we surveyed about 45 countries globally. Now, what you see here is an anesthesia circuit. And tens of thousands of anesthesias are performed using this circuit, which connects the anesthesia breathing machine to the patient. In North America, majority of these circuits get thrown out after every single case. So on an average, if we have, I do say 5 cases a day, I use 5 circuits a day. And we wanted to compare ourselves, not just with high income countries, but middle and low income countries, and understand what the practice patterns for this circuit usage were. Now you can see that here only 4.3% of circuits are reused in North America. While in high income countries, Germany, France, Australia, New Zealand, majority of these circuits are used up to either 24 hours, 3 days, or even 7 days. Germany actually has a policy where each anesthesia circuit is used up to 7 days, just changing the filter. So we're conducting a life cycle analysis right now, looking at the impact of this and working with departmental institutional policymakers to see how we can bring back reusable circuits here within our department, but then expand across other health systems in the country. So this is a really exciting opportunity because it highlights the data and evidence is there. It's the same scientific papers that are read by our colleagues in North America and Germany and Australia. But because of self-inflicted limitations at a departmental, institutional, and national policy levels, it's leading to a lot of waste and landfill and use of single-use plastic. Right. So we can't do this alone, and we wanted to sort of expand on how do we engage other people? People at frontline, nurses and staff that work every day across different floors, in the clinics, in ICU, in ED, to see waste opportunities. And with that, we've created this QR code. But what is really exciting is the tool that we've created on the back end. And if you click this QR code, it will tell you, like, where do you see waste opportunities, right? And we've divided it into scope 1, 2, 3 categories. And whether it's energy, pharmacy, food waste, in your work area, where do you see this? How often do you see this? What are your solutions? And so this is something that we're going to really focus on this year across UCSF Health to collect data and work on mitigation efforts in that area. So last but not the least, I wanted to say that as we all embark, and there is an urgency to get us to healthcare decarbonization goals because our current way of work cannot continue. It has a big impact, not just on our planet, but the patient that we swore to take care of. The one word I would leave you with is rethink. Rethink how you're doing everything. Dr. Sherman mentioned, is this lab draw necessary? Right? Does the patient need to travel this far? For us, we are rethinking whether we needed to use single-use textiles, circuits, refuse evidence and data on single-use devices, work towards circular economy, and then all the way down to recycle. But the focus has to be upstream and not downstream, because that's going to help us get there as fast as we need to. We're not alone in this because the Joint Commission says, and that was a big thing. Often when it comes to infection control risk, people say, oh, the Joint Commission wants this, and this is the Joint Commission standards. But luckily, Jonathan Perlin and others have made environmental sustainability a priority for among the top 3 priorities going forward. So there's a lot of support that is happening nationally and globally in this area. And the choice is ours. We have to decide how we're going to look at data, science, evidence, and how we're going to implement it in our daily practice. So thank you, and I think I'll leave some time for questions from here.
Thank you both for that, for providing your perspectives on sustainability in clinical care, and for also providing some ways that clinicians could get involved in sustainability in their own practice. So I have I made some observations. Jody mentioned there are systematic and structural issues that are barriers, of course, to sustainability work. Seema, you mentioned hours dumpster diving. So I'm curious, like, how can we make integrating sustainability into clinical practice like easier? What are some of the barriers that are getting in the way? And if you could speak to some of those barriers and what others can do to support your work, that would be great too. And you've mentioned some of these things already. And I think Dr. Sherman is having some, oh, here she comes. Thank you. So the question is, how can we create all of us, the rest of us, support you all in creating this culture of climate awareness and sustainability? And what are some of the barriers that you're seeing on a daily basis? And you've mentioned some of this already. It's kind of a two-part large question.
Jody, if you want to go first.
I think the issue is really quite obvious to clinicians. I think what has to happen firstly is to talk about it openly, model practices, call attention to issues just in our daily practices. And also, I mean, for me, I just got involved by asking, why is it this way and why can't it be different? And that sort of led me down the path of understanding where the real structural barriers are. But I think importantly is that everybody can do something. So it really just starts with modeling good behavior and talking openly about it, especially if we're in teaching institutions, but not exclusively so, that we shouldn't just accept that things are the way they are. And the other is to be involved in our professional societies. I think I don't know how many professional societies now have a dedicated committee that focuses on sustainability, but it is becoming more common. And if there isn't one, people should start one, because I assure you, you're not alone.
And Sapna, I completely agree with what Jody said. And I often tell med students who are like, oh, what should I do? And say, something that bothers you is a great place to start. And honestly, a lot of these projects or case studies that I've been involved in was things that were bothering me. Why are we doing this? Why are we not doing that? So I think that but knowing that there's a lot of support and you're not alone, I think that's one way to look at it. And then the second thing is that often, like, is this a bottom up or is this a top down solution? And my answer is that it's both. But the more I work in this space, I realize we will get there faster, as fast as we need to, if we get involved in policy, if we are a voice with our societies and getting involved with our administrations, getting involved with the C-suite, convincing people that there is a value, and the value is sustainability is green. It's good for business. And often I feel like I find myself making that argument that sustainability is very good for business. And then the way people can be involved is, I sort of highlighted those 4 pillars, whether you're an educator, making this an educational priority. If you're a researcher, making this a research priority, a QI priority. And for clinicians and mitigators, start every syringe matters. But across all of that, I feel education is important. And the very fact that we're having these dialogues is a start to the solution.
Thank you both. And Seema, you mentioned one way that students can get involved. There was a question in the chat about that as well. I don't know if you have, either of you have any brief additional thoughts on how medical students in particular could get involved? Pursue something that's bugging them?
I think that medical students are in an extremely powerful position. And I sort of equate them to my children. I don't do things for me that I would do for my children. Right? So if the medical students would go to their administrators, their educators, and say, hey, we want to learn more about this topic. We want to get involved in QI that's focused on sustainability. Why is this not a part of our didactics and curriculum? I think medical students are extremely powerful in the questions that they ask. So please know that your voice is heard, and you have to go and talk to your educators, talk to deans and advocate for this to be included in your curriculum?
So there are some really interesting questions in the chat, and I just want to recognize we probably won't be able to address all of them in a lot of detail, but two that are standing out to me is like barriers, pushback from infection control and risk management, and our payer system. Are there opportunities there for supporting climate action in clinical care? Again, I recognize that's a big question.
Yeah, well, I'm happy to go next. I would say it's a big challenge. This is why we don't have a choice but to get involved on a systems level. Like, we can do so much at the clinical level to be resource stewards and to avoid inappropriate care. And to get involved to the best that we can with quality improvement projects to try and normalize waste reduction. But our hands are frequently tied, particularly around infection prevention and control. And for those particularly not at UCSF, for lack of institutional buy-in. So on the payer side, we've certainly, there's several articles written about how the Centers for Medicare and Medicaid can incentivize sustainability in healthcare through value-based payment reform, which is really designed to control costs and improve the quality of healthcare, which is why we try and say that this is a dimension of healthcare quality. So value-based payment reform is a very big opportunity, and there are already performance improvement measures in our specialty of anesthesiology around fresh gas flow management. So low fresh gas flows, for example, as Seema presented, is an optional measure. But there are other opportunities that CMS can pursue, and they're looking at it now. In terms of infection prevention control, we recently published an article that looked at some of the systemic things that we can do to try and improve that. But importantly is to challenge the evidence. Part of where our hands are tied is that we have to hold true to whatever the equipment and instructions for use say, the IFUs. And those IFUs are being written intentionally to make it cumbersome to clean and reuse things. And so that is a big barrier for us. But importantly is to challenge the evidence. So there are areas if you challenge the evidence, and that means just getting involved, becoming friendly with your infection prevention team and developing that relationship and getting more involved. Seema?
Sapna, and yes, we've sort of faced some of the challenges as well. Often in a lot of products, it's about infection, patient safety. And I think reminding people that these current practices that we have are also contributing to the emissions that is in fact harming patients further, right? From multiple perspectives, whether it's just supply chain resilience. The other thing I talk about is globally, I think looking eastwards, that is also very important, because that's what the circuits, for example, the survey was looking at our peers and seeing how they're doing, because the evidence is the same. The bacteria and virus doesn't differentiate between Germany and the US, right? So I think that looking eastwards and seeing what our peers are doing and being involved in advocacy, talking to your infection colleagues, it takes a long time. And that's why I say that working with societies and policymakers is going to be crucial.
Well, thank you. I appreciate both of your responses, and thank you both for your time today. And we're unfortunately out of time, so I know there are a lot of other questions. We will make this webinar available as a recording, and we'll share the link to the recording with folks who attended, and we'll put it on our website, of course. So as we mentioned at the beginning, we will have another webinar on decarbonization on December 20th, actually, so you have to wait a few weeks. That one will be focused on building infrastructure and energy use. And before then, we'll have a few other events from the Center for Climate Health and Equity, including a symposium on health education and climate action on November 8th, and a book talk on the climate crisis by the author, Dr. Susan Barrow-Wu, president of the Mind and Life Institute. We will be sure to share the details with all attendees, and we hope to see you at these events. So in the meantime, thank you again to Drs. Gandhi and Sherman for joining us, and for all of you for listening in, and I hope you all have a wonderful day. Take care.